assessment of the neurological system. The neurological system encompasses pretty much everything we do. The nervous system controls behavioral and cognitive functions of the body, involuntary and subconscious functions as well. Almost anything that's going wrong in the body might have a neurological component. During this module, we'll talk about anatomy, taking a history, and doing a physical exam on this body system. Let's start first with anatomy. Remember that the neurological system has two main parts, the central nervous system and the peripheral nervous system. For this class, it's fairly simple. You have to remember that the central nervous system is the brain and the spinal cord. The peripheral nervous system includes the cranial nerves and the spinal nerves. Thinking about the brain, to be really simplistic about it, it has three main parts: the cerebrum, cerebellum, and the brainstem. Think about the cerebrum being the cognitive area. It's mostly in charge of memory and learning and knowledge. The cerebellum has more to do with coordination and balance. And then think about the brainstem as being mostly concerned with vital life functions, so keeping the organs functioning, and the sleep-wake cycle. Now, of course, these three areas of the brain are not entirely independent. They do talk to each other, and each one of them might be somewhat involved in the work of the other two. I'm being rather simplistic here. I think of the spinal cord as being a little bit like Hermes in the Greek pantheon. The brain might be Zeus, in charge of everything, and Hermes is the messenger of the gods. So the main job of the spinal cord is to bring messages from the brain to the rest of the body and bringing messages from the rest of the body to the brain. On the other hand, once in a while, it can make its own decisions first without consulting Zeus or the brain, and we'll talk about that. The peripheral system is made up mainly of cranial nerves and spinal nerves. We're going to talk about each one in turn. Remember that the spinal nerves innervate along a pattern called dermatomes, and this is helpful to understand if someone's having a symptom or sign in a certain area of the body. These dermatomes correlate to particular spinal nerves and area of the spinal column. We're going to concentrate somewhat more on cranial nerves. Now, why do we learn the cranial nerves and learn how to test them? I remember when I was in nursing school, I memorized all these cranial nerves and how to test them, and I think only at a certain point later did I stop and think, wait a second, why am I doing this? Why do I care? And somehow I must have dozed off during that moment in the lecture or something. Didn't quite read that paragraph in the textbook. The idea is that certain diseases or conditions can cause an impairment of the cranial nerve. For instance, like a tumor or an infection along that nerve can inhibit its function. And one of the ways that we can pick that up is to test to make sure that that cranial nerve is working. There are 12 cranial nerves on each side, and we call them cranial nerves because they originate in the head, just inferior to the brain. But they're part of the peripheral nervous system. They're not part of the brain, they're part of the head. And mostly they innervate areas of the head as well, but not entirely. They emerge from the spinal column while it's still in the head, just inferior to the brain, on the left and right sides of the head. Some of these cranial nerves only bring messages from external stimuli to the brain. Some of these cranial nerves bring stimuli from the brain into the periphery, and some of them do both. Bringing a message from the periphery to the brain is called afferent functioning with an A. Bringing a message from the brain to the periphery, the brain telling part of the body to do something, that's called an efferent message. And some cranial nerves have just one or just the other, and some cranial nerves have both kinds, afferent and efferent functioning. Some of these cranial nerves are a lot more complex than we're going to give them credit for here. We're making it just a little bit simpler for this level, but if you become a neurological nurse, you might become an expert in some of the more subtle differences of the cranial nerves. So now let's talk about history and what subjective data you need to gather about this body system. In terms of a history for a neurological system, it's a little tricky because the nervous system innervates everything in our body and has to do with all of our behavior and all of our involuntary functioning. Almost any symptom or sign could be neurological in origin or have a neurological component. We don't necessarily know. So almost anything could be neuro. As always, we're going to get past medical history, family history, medications, allergies, review of systems. In terms of history of present illness, like I said, almost any sign or symptom could possibly be neurological, but specifically, we definitely want to ask about dizziness, seizures, vision changes, loss of consciousness. LOC sometimes is level of consciousness, or sometimes loss of consciousness, depends on the context. If anyone has ever fainted or blacked out. Any pain certainly might be neurological. Weakness, imbalance, tremor, problems with coordination, incontinence, or tingliness. Why is incontinence a neurological symptom? Well, the way you know that your bladder is full is that the bladder is sending messages to your brain telling it it's full. And then, in order for you to hold that urine in your bladder until you get into an appropriate place to release it, it requires the brain to do some work through nerves. So we need that nervous functioning to be intact. If it's not, you might not know that the bladder is full and you might lose some urine. When a patient reports dizziness, you're going to need to distinguish type of dizziness. We use dizziness to mean several different things in English. It can refer to vertigo, which is a sense of the room moving, even though the patient isn't moving. Vertiginous is the adjective. Another kind of dizziness is presyncope. Syncope means a loss of consciousness or fainting. Presyncope means the feeling that you're about to pass out. So that's a certain kind of dizziness. And then the third kind of dizziness is what we call sort of a catchphrase, lightheadedness. And it means you don't have vertigo, you don't feel like you're about to pass out, but your head just feels sort of funny. That kind of dizziness. That's lightheadedness. So if someone says that they're dizzy, or you can ask them if they felt dizzy, if they say yes, you want to try to drill down and see if you can identify whether it's vertigo, presyncope, or lightheadedness. We want to know if they're able to accomplish all their ADLs independently, or if they're having trouble, if any of the symptoms that they're experiencing are inhibiting their ability to accomplish their ADLs. We want to know about their alcohol use, other drugs, and cigarette tobacco use, as well as vaping. Make sure you get a pack year history with any tobacco use, and try to quantify drug and alcohol use. For more information on how to do that, check out the complete health history video in this series. We want to know if anyone has had any trauma, particularly to the head, but also to the neck or back, if they've had concussions in their history, or if they've had any traumatic brain injuries. These can have very long-lasting effects. We want to know where a patient lives, what they do for a living, and what kind of environmental toxins or hazards they might be subject to. Let's move to the exam now. The neurological exam is composed of several different sections. First of all, mental status testing, which we'll talk about in another video module. We're going to test all of the cranial nerves. We're going to test motor functioning, sensory functioning, reflexes, and cerebellar functioning. Don't forget the general survey. Things on the general survey that are directly related to the neurological system would include mental status, mobility, behavior, facial mobility, and gross auditory functioning. So are they able to hear what you're saying, or are they looking at your face, or turning their ear to you, or asking you to repeat yourself often? In terms of the cranial nerves, I want you to know the name of each nerve, its number, and how to basically test it. Like I said, some of these cranial nerves are a little bit more complicated than I'm pretending they are here, but we're going to do sort of a simple test for each one. The first cranial nerve is olfactory nerve. The olfactory nerves are on the right, left sides of our superior termitans up here, and they have to be functioning in order for us to be able to smell. So what you're going to do is ask your patient to close their eyes, block one there, and then give them something benign to smell, like coffee, or citrus, or cinnamon, or vanilla, and make sure that their eyes are closed so that they don't have that visual cue. You're going to ask them to keep their eyes closed and block their other nair and test with a different smell to make sure that each one of those olfactory nerves is intact. The second cranial nerve is called the optic nerve, and it allows for vision. If your patient has read a Snellen chart or a Jaeger chart with each eye separately, then we know that each optic nerve is intact. 3, 4, and 6, we tend to test together because together, the third, or oculomotor cranial nerve, the fourth, or trochlear cranial nerve, and the sixth, abducens cranial nerve, are responsible for the extraocular motion of the eyes. Also somewhat for perla, especially the third cranial nerve. But we can simplify it here, that if your patient can move their eyes in the 6 areas of all the 6 extraocular motion cardinal points with both eyes independently, then their cranial nerves 3, 4, and 6 are all intact. The 5th cranial nerve is called the trigeminal nerve. This is a little confusing because that word tri, of course, sounds like 3. And the reason that it's trigeminal is because the 5th cranial nerve innervates the face in 3 branches, like that. Okay? The forehead, upper cheek, and lower cheek or chin. And of course, there's 2 5th cranial nerves. All right? One of the most important things that 5th cranial nerve does is allows for sensation of the face. So we are going to test soft touch in each one of those 6 areas, the left and right, forehead, upper cheek, and lower cheek or chin. You can ask your patient with their eyes closed to identify a soft or sharp touch. Obviously, don't use anything so sharp it's going to hurt them. That's the trigeminal nerve. The facial nerve Sounds a little bit like the trigeminal nerve, right? But the facial nerve, or seventh cranial nerve, has more to do with the motion or the mobility of the face. So ask your patient to smile, frown, puff out their cheeks, lift up their eyebrows. If they can do all those things on both sides equally, the right and left are both moving on command, then their seventh cranial nerve is in good shape. One common disease that affects the seventh cranial nerve is Bell's palsy, and you'll notice that somebody can't move one side of their face well. Bell's palsy is an infection of the seventh cranial nerve on one side. The eighth cranial nerve has two names. That's not fair, except one of them is really an easy name, auditory cranial nerve. Or the fancier, complicated word is vestibulocochlear. It still has that hint in it. Cochlear is from the cochlea, the ear, right? And the eighth cranial nerve allows us to hear. So if your patient has passed a whisper test on both sides, then you know that both of their eighth cranial nerves is intact. The ninth cranial nerve is called the glossopharyngeal, and it's partially responsible for taste, as is the seventh cranial nerve a little bit. And it also allows for the protection of the gag. So if you touch the back of your patient's tongue or the soft palate lightly with a tongue depressor when you're doing their mouth exam, and it causes them to gag a little bit, then you know that that ninth cranial nerve is intact. This one we don't generally test the left and the right, but just one, anywhere in the mouth. The vagus nerve is partially responsible for our ability to talk, articulate, and also to swallow. So you've had a conversation and done a history with your patient, and they've been able to articulate their words, you know that their 10th cranial nerve is pretty well intact. You might have asked them to swallow when you were doing a thyroid test. So that's another way you can tell. The 11th cranial nerve is called the spinal accessory nerve. This nerve also leaves the head and goes into the shoulders. If you ask your patient to shrug their shoulders against resistance of your fist and to move their head to the right and left against resistance from your hands, you know that their 11th cranial nerve that innervates the trapezii and the sternocleidomastoid muscles, you know that that cranial nerve is intact. The 12th cranial nerve, you'll notice it also has that root glosso, like in the 9th cranial nerve. Glosso means tongue, and the 12th or hypoglossal cranial nerve controls tongue movements. So if you ask your patient to stick out their tongue, move it to the left and to the right, up and down, you know that their 12th cranial nerve is intact. Now, let me point out that you're asking your patient to do these tests, and if they can do these tests, then we know that the corresponding cranial nerves are intact. However, if they can't do those things, for instance, if I'm asking my patient to do a left-sided whisper test, and my patient can't quite hear on the left side, it may be that their left cranial nerve 8 has a lesion pressing on it or a disease, but it might mean that they have congenital deafness or their ear is stopped up or that they have otosclerosis. Hearing requires nerves to be intact and also other things. Same thing with the optic nerve and all the cranial nerves. If someone can't see well out of their right eye, it might mean that they have a problem with their right second cranial nerve, or it might mean that they have macular degeneration or glaucoma or a cataract. We need several things to be working in order for that process to proceed successfully. So if your patient can do the things that you're asking them to do when you test the cranial nerves, you can say that that cranial nerve is intact. If they cannot accomplish the task that you ask them to do, we cannot say that their cranial nerve is impaired. You'll have to write out in a narrative form what they are unable to do. Patient unable to identify smell through their right nair, for instance. And that would mean that there would be further assessment needed to figure out whether it's the cranial nerve or some other part of the body that's having a problem, or both. The traditional mnemonic to help you remember the names and the numbers of all the cranial nerves is on old Olympus towering top, a Finn and German viewed some hops. If you do a quick Google search, you're going to find a whole lot of other mnemonics. Some of them are pretty racy and not something that I'm going to repeat here, but whatever helps you remember those names and numbers works for you, it works for me. Another section of the neurological exam we're going to do is motor function. We're going to talk about this more in the musculoskeletal module, but for now, we're mainly concerned with bulk, strength, and involuntary movements. You're going to ask your patient to pull against your arms and to push with their lower extremities and their upper extremities. You've already assessed their spinal accessory nerve or trapezii, so you have a little sense of their motor functioning and their strength. You'll notice if someone has a particular weakness on one side or the other, that may be a neurological problem. We want to see if a patient's major muscles are atrophied and always compare left to right sides, because that can often give you a hint as to something being a problem. We want to assess their gait. Are they limping? Are they loping? Do they seem to have controlled, coordinated movements? Do they have what's called ataxia, or a difficulty controlling their movements? They've lost any grace. There are a lot of ways to measure sensory function in patients. And honestly, the ability to distinguish light touch versus temperature versus pain versus position in space are all slightly different. And if you go into neurology, you might learn quite a lot of real fancy diagnostic assessment techniques. But what we're going to do in this class is really worry about light touch sensation on the face. Think about both the right and the left trigeminal nerves. And then also we're going to test the hands and feet. And the reason why we're going to test the hands and the feet are, if you think about all the different neurological problems that people might have, one of the most common reasons why people have neurological problems in this country is the neuropathy of diabetes mellitus. Diabetes is exceedingly common and, if uncontrolled, can lead to neuropathy in the periphery, particularly the feet, which can cause huge problems for mortality and morbidity. So I want you, as a new nurse, to make sure that you're testing sensation in the feet and the hands, as well as the face. With eyes closed, ask them to distinguish between sharp and dull on the feet and the hands. If they have a problem distinguishing in the periphery, then move the test somewhat proximally and see if they're able to distinguish touch more centrally. In a full neurological exam, we'll also test deep tendon reflexes. And in order to understand that, let me first introduce the concept of the reflex arc. Remember how I said that the spinal cord sometimes has a bit of executive function that it can do without consulting the brain? Well, that's where the reflex arc comes in. Evolution has made it so that we're able to react to a danger, even saving the split second of time that it would take to get the message up to our brain and back down to our body to do something to avoid the danger. So for instance, if I put my hand over a flame, the message will go to my spinal column, and before it even goes up to my brain, there's a message coming out from my spinal cord back out to my arm to get my hand away from that flame. Simultaneously, there's also a message going up to my brain to tell them what's going on, but meanwhile, my hand's already starting to move away from the flame. So you can see how this is a really good protective mechanism that evolution has given us. That reflex arc we can test using deep tendon reflexes, or DTRs. I'm going to show you how to do DTRs in certain areas of the body, and you're going to grade the DTRs from 0 to 4. 0 means no response. 2+ is a normal response. A diminished or low response would be a 1. A rather brisk or strong response is a 3+. And a 4+ means so strong it even has an echo or a clonus movement. The deep tendon reflexes that you're responsible for are going to be the biceps DTR, the triceps, the brachioradialis, the quadriceps, otherwise known as the knee reflex, and the Achilles reflex. We're also going to do something called the plantar reflex, or Babinski, which isn't exactly a deep tendon reflex, but it's a reflex nonetheless. When you test the quadriceps, make sure that you are standing to the side of your patient so you don't accidentally get kicked. You're going to try to use a quick, rapid strike of your hammer to the tendon. Hopefully you're going to do your best to make your hammer strike perpendicular to the tendon. It's helpful if you can palpate the tendon before you strike it. So you make sure that you're hitting the right area, and use a quick motion from the wrist like you're throwing darts. Don't just push on it. For the biceps, you're going to put your thumb against the tendon that you find in the antecubital space and use the hammer to actually strike your own thumb. That will put the vibration into the tendon and cause the movement. You'll see a small curling or flexion forearm and wrist. The triceps tendon is about here, and you're going to try to hit it perpendicularly, like so. The movement you expect is a small momentary extension of the arm of that. The brachioradialis tendon is approximately here. You try to strike it perpendicularly like so, and you'll see a small flexing movement of the wrist and fingers. The quadriceps tendon is approximately here. Try to strike it perpendicularly with a quick wrist flipping motion, and you should see a quick momentary extension of the leg. For the Achilles tendon, it's very easy to find, of course, but it's going to be a small plantar flexion movement of the foot if you strike it. It's such a small motion that sometimes it's helpful for you to place your hand very, very lightly on the plantar surface of their foot, so that when you strike that Achilles, you can feel the foot moving down against your hand momentarily. The Babinski reflex is a reflex on the sole of the foot. With this end of your reflex hammer, move it in this shape along the sole of the foot. You'll notice that in anyone but a newborn, the toes will curl in or go down just a little bit. Now, this might be ticklish for your patient, so they may bring their whole foot a little bit away from you, but you're not talking about the foot itself or the leg. You're looking at the toes themselves, and they'll curl under unless someone has some major neurological damage. If someone has particular kind of major neurological damage, instead of curling toes, they might have their toes fan up like that instead of curling in. That's also what you're going to see as a normal response in a newborn. If you do this Babinski reflex in a newborn, they're going to fan their toes up and out, like so. So we tend to say curling or down going versus up going or fanning as a reflex. In terms of documenting your DTRs, you can use a stick figure like this. Think about which number would correspond to each reflex. Make sure you know how to read a chart like this and how to make one. You could also do it in the narrative or bullets format. A Romberg test is something we particularly do with someone with ataxia, but you're going to learn to do it on anyone so that you have it in your toolbox. It's a fairly simple test. You're going to ask your patient to put their feet together, their arms down at their sides, and close their eyes. We want to see if over 30 seconds they can hold their balance. A little tiny bit of swaying is okay, but if we see someone fall or have to open their eyes to keep standing up, then there's something wrong with their cerebellum, and that would be a positive Romberg test. Negative means that they can keep their balance for 30 seconds with no more than minimal swaying while their eyes are shut. When someone's doing a Romberg test, stand nearby them with your arms out just in case they do lose their balance. You don't want them to fall and hurt themselves. We're also going to test the cerebellum by using something called RAMs, or rapid alternate movements. There are different ones we can do. We can ask our patient to rapidly supinate and pronate their hands on their lap, back and forth and back and forth and back and forth, or touch their fingers to their thumbs alternately and rapidly. Or you can ask someone to touch your finger with their finger and then back to their nose and back to your finger and back to their nose and move your finger around so that they have to follow it in a coordinated way. For the rapid alternate movements, it's vitally important that, one, it's rapid, it happens quickly. So it's not about the person thinking about what they're doing, but actually a coordination skill, and that it alternates back and forth, back and forth. So those are RAMs. You should have at least one RAM if you're doing a full neurological exam or a head-to-toe physical exam. One other way that we assess the cerebellum is gait. We want to know if our patient can walk with ease, evenly, gracefully, with coordinated movements. Another way we can test the cerebellum, balance and coordination, is asking them to bring their heel to their shin, run their heel up and down their shin fairly quickly on each side. That's a good test of coordination as well. So if you've tested your patient's cranial nerves, their motor function, their sensory function, their reflexes, and their cerebellar function, as well as doing a full mental status check, you've got a great neurological physical exam.